Good afternoon, everyone, and welcome to our winter webinar series sponsored by the Early Intervention Training Program at the University of Illinois Urbana-Champaign. Our topic today is Let's Eat Together, Responsive Feeding and Early Intervention. And we are presented today by Stephanie Cohen and Karen Dilfer, and they will tell you a little bit more about themselves when they get started. Welcome, Stephanie and Karen. Also on today as moderators, myself, Maria Maddox, and Alyssa Jones. We're both here to help in the background to make sure that everything's working okay for everyone. So if you have any issues, I'll tell you how you can tell us here in just a moment. Hopefully everyone can hear me okay. And if you haven't, that you have set up your audio wizard to make sure that your speakers are working just fine. Also in the chat box, I've posted a couple of times the link for the handout today, as well as some other links for additional documents and videos and things that our presenters wanted to share with you ahead of time. I'll post those again as we keep going. So our webinar's awesome. We get to take care of these things wherever we are. We didn't have to get in the car and drive, and right now it's just above freezing where I'm at, so the weather it's nice in the room that I'm at. So anyway, webinars are pretty awesome in that regard. But some of you may be wondering, okay, so I'm doing this, how do I get my credit? How do you guys know I've attended? So you should get, after our webinar is over, an email from the EI training program that includes an evaluation survey. Your responsibility is to look for that email and then complete the survey that's attached. And once that survey is completed, in about 24 hours time after that, you will get a certificate of attendance. So just remember that if you are right now logging in as a group, you will each have needed to register, and that way you can get that individual email from the training program. Now that email will probably come to you sometime after the webinar ends today. It's usually around 2 o'clock, but it may be somewhere right around that time, so be looking for it there. All right. So as I said, webinars are awesome. One of the downsides to webinars, though, is that you can't see us. We can't see you, and so we're missing a vital part of communication, which is, that personal, face-to-face, nonverbal type of communication. So to make up for that, we have got some tools that we're going to use with our webinar that allow us to communicate and to make sure that we're all on the same page, all of those things. So I want to draw your attention to the slide, and you'll see I've got on here a copy of what the screen should look like for you. And what I'm going to direct your attention to is the control panel. So if you are logged in on a computer, your control panel should be right on the left-hand side of your screen. If you are logged in on a handheld device, so a phone, yours should look something like that pictured on the left. If you are on a tablet, yours is going to look like the phone, except your chat, let me draw my pen here, your chat box is probably going to be over on the right-hand side of your screen. So in your control panel, there are a couple of different tools that we are going to use today. The first one I want to draw your attention to is the hand raise tool. So depending on what type of device you are using, you'll see where the hand raise tool is. So yeah, so we might use this as our presenters might ask, how many of you have ever participated in a webinar before? Why don't we just ask that question? How many of you have participated in a webinar? If you have, go ahead and raise your hand. We'll give folks a few minutes to do that. All right. We got quite a few folks that have participated. So once you've raised your hand, then you can click it again, and that will lower your hand down. So go ahead, and if you've raised your hand, go ahead and lower it down again. Great. We're going to be using this tool a couple of different times. All right. Our next tool that we're going to use is the chat box, and some of you have already found that. And you'll find that on the screen, if you're on your computer, you should have at the very bottom where you can type in. And we're going to use your chat boxes to be able to ask questions of the presenters, get clarification from the material that's being presented, to say hey to somebody that you haven't seen in a while, that you see their name in the participant list. You know, whatever, this is going to be our main source of communication for today. So be sure to use your chat box to address any questions that you may have. And here's a tip. If you have a question, go ahead and type it in. Don't wait. Because we will have question breaks built in throughout our session today. And we'll address those questions during those breaks, but it's nice to have the question already present and ready so that we can address it as soon as we get to that break. So if you do have any questions, just go ahead and type them in. Now, a couple of things about that too. I have a pretty good idea of what our presenters are going to be sharing today. So if you ask a question, and I think our presenters are going to be talking about that later in their presentation, I may not bring it up right in that first break. I may just wait until we get to that point where I know they're going to talk about it. So if you do type your question and you feel like, wait, hey, they haven't said anything about my question, it's okay. I know it's there. We'll get to it, I promise. So that's the chat box. The other tool that we're going to be using is the polling function. So right next to, under your name, where those boxes are, that fourth box is a polling function box. It'll either look like it's on the screen where it's got a little checkbox in it, or it'll look like what it does now for you guys, and it'll have a little A in it. So we're going to use this tool to ask a few questions and get some general information. These kind of questions help us as presenters make sure that we're all on the same page and understand. So anytime that we have a poll or a hand raise, or our presenters ask you to respond to a question in the chat box, please do so. That lets us know that we're that you can hear us and that we're making a difference here. So let's start with our first poll, and I've already got it set up here on your screen. Who do we have participating with us today? So if you are PT, OT, speech, DT, or CFC staff, you've got options A, B, C, D, or E. If you are an other, type that in your chat box. And if you please use the polling function, so click on that fourth box under your name. Okay, there's 4 boxes under your name. The fourth box is the polling function. Click on that. It'll open up that drop-down box, and then you can click on your response. So, and everyone should have the polling function available, whether you're on a computer or a handheld device or a tablet. So, and then we'll give folks a few more seconds to find that. Okay, and then I think we can probably post results. Let's see what we've got here. So we've got Stephanie and Karen. It looks like we've got a lot of speech-language pathologists, quite a bit of folks from CFC staff. That would be mostly service coordinators, I believe. And then a mix of other folks. So as you can see in our chat box, we've got behavior analysts, dietitians, early intervention supervisors, nurses, some early childhood special education folks. So we've got a wide variety of folks that are participating in our webinar today. All right, folks, I'm going to clear that out, and I've got another poll for you, so let me switch over here. So our presenters wanted to know kind of what your experiences are in relationship to feeding issues in your practice. So if you will go to the polling function again, under your name, that fourth box under your name, click on that fourth box, open it up, and put in your response there. Instead of typing it in the chat box, if you can find the polling function on the tool under your name, that would be most helpful, because then we can kind of see, we can post those results and see. So your options are that you deal with feeding issues pretty much all the time, or maybe your next one is about half of your practice is that, or maybe you sometimes just deal with feeding issues, or perhaps you have no experience at all. So I'll let you finish filling in your answer for this poll. I'll give you another couple of seconds here. Ashley actually works with you, Stephanie. All right, so let's go ahead and post the results here and see what we've got. All right, so it appears that the majority of folks either deal with feeding occasionally, sometimes, or they work closely with others who deal with feeding. So you've got a handful of folks that it's their primary role or predominantly, but the majority of folks are working with feeding issues on the periphery or just on occasion. All right, so that tells you a little bit about our participants today, Stephanie and Karen. So with that being said, I'm going to turn it over to you and let you take it away.
Hi there. Thanks so much for that introduction. It's great to be here with you all today. This is Karen. I'm here with Stephanie Cohen. We are in snowy Northbrook, Illinois. And so we just want to channel our view of this beautiful, sunny, snowy backyard to you all. We thought that we'd just take a minute to introduce ourselves. My name is Karen Dilfer. I am an occupational therapist, and I really love to support families in helping them with their kids who have a hard time eating. I have a little bit of a strange background because not all occupational therapists are as interested in feeding as I am, but more than a couple years ago, I had the opportunity to study with Marcia Dunn Klein, who was one of the leaders in the field of pediatric feeding. So I did a postgraduate fellowship with her, and I worked with her in her clinic in Arizona for a while. And then I realized that I really, really love feeding kids, but I also really, really love the Midwest. So I came back to Illinois. So I've been working as an early intervention provider in the state of Illinois since then. And it's my pleasure to work with all sorts of skilled professionals who also feel strongly about supporting families and feeding kids. And Stephanie is one of those people. So Stephanie and I collaborate quite a bit, and I'm going to let her introduce herself right now.
Hello, everyone. We're so excited that you all have joined us today, and we're really excited to just be part of this conversation around feeding and early intervention. We have collaborated around this work for quite some time over the last couple of years, or last few years. Personally, I have practiced in a variety of settings. I started off in a multidisciplinary clinic. Some of you may know it if you're local to this area, Pathway Center, which is now the Shirley Ryan Ability Lab. Then I spent some time at La Rabida Children's Hospital in the south side of Chicago before transitioning into private practice full-time. My additional area of clinical interest is breastfeeding, so I'm a certified lactation counselor, and at this point in my practice work exclusively with families who are helping their children learn to eat.
Great. So we wanted to extend thanks to the Early Intervention Training Program, Susan Connor and Maria Castanis especially. And then we also just wanted to say thanks to Maria Maddox for all of her support and for being our moderator with us today. It's so fun for us to be here. So before we start and we start talking to you, we were hoping that you could take a minute and just think about your own practice. And think about a family who either you worked with in the past or you're working with right now that has a little one who is struggling to eat. So just hold that family in your mind, and we're going to come back to that in a little bit.
We wanted to start off by talking about mealtimes. You're going to hear us use the word mealtimes throughout the presentation today. because we are encouraging all of you to think about feeding with a wider lens. So with that in mind, we'd love to hear from you and have you type in your chat box some of the things that happen during mealtimes outside of just the consumption of food. So if you could use your chat box and send us some of those things, we'd love to discuss some of them. Socializing, conversation.
Bonding, that's a great one.
I saw parental pressure in there too. Yep, that can definitely be happening. We'll talk about that. Talking about the day, prayer, nutrition, connection, argument. That's definitely going on.
I've never had a stressful mealtime in my house.
Me neither.
No, they're always pleasant.
Textures, sensory, laughing. I love these. Watching television or videos, absolutely. Some of our families are doing that to different extents. Competitive foods and behaviors. So lots of great ideas coming through in the chat box. We wanted to make sure that we're really thinking about all of the different things that happen during meal times with our families. So of course, right there at the top is nourishment. And throughout the talk, we're going to be talking about a lot of the different aspects of meal times with the understanding that a child's nutrition and growth are of primary importance. But you may not always hear us highlighting those as we're talking about different aspects of mealtime, because there are some other things that we want to bring your focus to. Skill mastery, family time, giving and receiving love is a big one that Karen and I have talked about a lot. Sensory experiences, which some of you mentioned, exploration and communication.
So in an ideal world, mealtimes would always feel good. And we've got a couple little pictures on the slide to show you what mealtimes with little kids, might look like. We like to think about mealtimes feeling good in a number of different ways, but as someone who has the opportunity to just be a third party and kind of look in on other people's lives, we know that when parents offer kids food and kind of lean in, maybe with a little spoon, or they offer and put a little food on the child's tray or offer it in their hand. And when we see kids who lean back and say, "Oh, that looks good, Mom," or "Oh, that looks tasty, Dad," we have this idea of a positive tilt. And it's something that's really important to think about as we're thinking about the relationships between parents and kids and how parents offer food to their kids and how their kids respond. So we're going to take a lot of time today to talk about how this idea of relationship is important in feeding and how we as those supporters from the outside can really encourage the development of the relationship between parents and their kids. So one of the things we want to highlight early on is a relatively new research paper. This paper came out roughly 2 months ago, and it was put out by a group called Feeding Matters. I believe that you've got the link to the Feeding Matters organization in your handouts. And Feeding Matters is a national organization that was started by some parents who had kids who were struggling to eat. And over the past 11 years, Feeding Matters has accomplished a number of initiatives in supporting the greater feeding community, both on a local level and a national level. And most recently, they published a paper with a number of different researchers from across the United States that looked at giving a name to some of those challenges that kids have with feeding. So as people who work with families who have kids who struggle to eat, you guys know what a feeding struggle looks like. You know when it looks like a little one isn't growing well, or is refusing the spoon, or there's really stressful meal times. But a number of people in the medical community, don't understand it the way that we understand it as professionals. And so this group published this paper in order to give a name for that thing that doesn't really have a name. It can be really easy for a family who has a child who's struggling to eat to go to an office visit of maybe a pediatrician, maybe a different medical specialist, and say, "My baby's not eating," and the professional will come back and say, "Oh, well, they don't have a diagnosis, there's nothing wrong." So we wanted to just talk about this paper because it's new and it's interesting and you might want to look it up, but also because we want you to be familiar with this terminology. We also want you to know that we might refer to this terminology and we might use pediatric feeding disorder as we're talking today.
So we wanted to start off by talking about some of the things that might co-occur with feeding issues, might cause feeding issues. We're going to highlight some of the diagnoses you might come across in your work and some of the experiences that our families may have had prior to getting to us. We want to start off by talking about this first box on the left, developmental experiences or lack of experiences. This is such a big one, and it really is going to kind of set the tone for this talk, because everything that we talk about after this has the potential to impact a child's developmental experiences or prevent them from engaging in the developmental learning experiences that we know help kids learn to eat and enjoy mealtimes. So if you think about your own learning around food, or if you're a parent, or if you have a child in your family who you've watched learn to eat, we know that every experience we have teaches us something about eating. And when things go well, we learn that eating is fun and it satisfies our hunger and generally just feels good in a lot of ways. But when a child has a medical need that requires intervention, perhaps they were born prematurely, they require a NICU stay, their skills are immature, and they're struggling to eat, things can easily go off track. And throughout those experiences, that child may learn that eating is scary and stressful, and maybe that baby also has a period of time during which he or she is dependent on ventilator support and not able to eat by mouth at all. So those babies are really missing out, and older children as well, maybe missing out on a lot of those pleasurable oral sensory motor experiences that support the development of feeding skills, but also that allow for secure attachment and establishing trust with their primary caregivers. And we're going to refer back to this idea of attachment and trust throughout the rest of the talk as well, so you can really understand why the work that we do as early intervention providers around relationships and supporting caregivers is so, so important. So this is not the only situation in which this disruption can happen, but just one example that we thought would be a good one. We highlight mental health, anxiety or depression. We know from the literature that mothers in particular who experience depression or elevated levels of anxiety or stress, perhaps due to a history of trauma, which Karen and I talk a lot about, have disrupted relationships with their children. So it's harder to form that secure attachment. It's harder for moms who are struggling at times to really tune into their children's cues and be responsive. So it's something that we think about when we meet with families is what are the parents' backgrounds? And when we think about the idea of anxiety and stress, we also think about it as it relates to the children that we're working with. If a child has had multiple stressful experiences around eating, they have learned that it can be scary. And so we really want to think about how we're going to start to tip the scale in the other direction and build some more positive experiences that can help a parent and a child feel calm and comfortable. Environmental challenges. So this is, as simple as is the family homeless? Where are they having mealtimes? Do they have a place to share mealtimes in their home if they do have a home? Do they have appropriate supportive feeding for their child? Do they have access to resources like, a variety of nutritious foods? So we're really thinking a lot about what has been available to this family in their journey supporting their child learning to eat. Neurological problems, we're not going to dive too deep into many of these, but we'll just list a few. So you may have kids on your caseload with cerebral palsy, meningitis, a traumatic brain injury, conditions affecting neuromuscular coordination like muscular dystrophy, spinal muscular atrophy, unexplained hypotonia or hypertonia. All of these things have the potential to impact a child's ability to manage a variety of food textures and consistencies safely and efficiently. Anatomical abnormalities. So these are our kids with craniofacial disorders, things like also laryngomalacia, tracheoesophageal fistula. You might hear some of these terms or read some of them in your intake paperwork or medical documentation. So if there are things that you're not quite familiar with, we encourage you to do a little bit of research before you meet with the family so you understand what you're looking for and what support the families might need. Incoordination and dysphagia. So this is incoordination is kind of a more general term, but dysphagia is difficulty coordinating function in any of the 4 stages of swallowing. So oral, oropharyngeal, pharyngeal, and esophageal. And a lot of this information, it comes from a variety of sources, but you can find more details about a lot of the things that we're referring to on the ASHA website in the practice portal. There is a very comprehensive document regarding pediatric dysphagia. So that's the organization, the National Organization for Speech-Language Pathologists specifically, but it's a document that's available to the general public. And we can certainly direct you towards resources for a variety of disciplines. If you're interested, just reach out to us. So poor growth, we want to highlight that this can be part of a number of the other things that we're highlighting, but the reason why we put this in here and wanted to touch on it is because this is the parameter that is most frequently stressed at physicians' visits and home visits. So there's a ton of focus on the baby's growth. They're not growing, they're not eating enough. And so what we want to think about as practitioners coming in and supporting the family is that that's a pretty stressful thing that families are hearing over and over and over again. So we'll get into how to balance that a little bit later. Prematurity, so we talked a little bit about how prematurity impacts feeding challenges. We have a larger number of babies who are surviving at younger and younger gestational ages, and the prevalence of feeding problems in premature infants is very, very high. Sensory sensitivity or hypersensitivity, so we know that children have different sensory processing systems and they experience the world in all kinds of different ways, and we're always thinking about the child's experience integrating all of the different stimuli at meal times and from food when we are working with families. The last one is just a huge category. We could, spend a whole session on that, but chromosomal abnormalities, syndromes, and diseases. So things like Down syndrome, things like Pierre-Robin sequence, Prader-Willi, or other complex medical conditions, heart disease, pulmonary disease, gastroesophageal reflux disease. The one thing that's not on this slide that we encounter quite frequently that should be is food allergies and intolerance. So we often encounter children who are sensitive to something in their diet that's causing them pain or discomfort that goes undetected for quite some time. So that's another one to be thinking about.
We just want to say that when everything goes right, kids want to eat, right? If any of you there have ever had a baby and have gone through the process of bringing that baby home and feeding them, parents look to kids for food, and then parents want to feed their kids, right? Like, feeding is a reciprocal relationship. So when that doesn't work the way that it's supposed to, and kids don't look to their parents to eat, it's the job of everyone else on the team to say, what might be going on? So when I think about it in those terms, it gives me pause, because a child might not be eating because they're protecting themselves. Maybe they have really bad reflux and it hurts every time that they eat. Or maybe, I've had kids on my caseload who no one really quite knows why they're not eating, and then some medical testing discovers that there is an anatomical abnormality that makes it really, really hard for them to eat because the food is going to the wrong place in their body. So we just want to be sensitive as those professionals in the lives of children to say, you are telling us something by your behavior. What might be those things that you're trying to tell us? Because you can't use your words because you don't have them yet because you're too little. This quote by Ellen Satter, who, again, is one of those wonderful people in the feeding world who might be a resource to you, really kind of encapsulates the spirit of that, when feeding goes well, parents and kids are in it together, and it's really great. But if a child isn't interested in being fed, we want to figure out why that might be. Another thing to think about is that, for all of you out there who have kids, if you've fed your own kids, you know that kids eat constantly. It can be a full-time job to feed a baby. It can be a full-time job to feed a toddler. It can be a full-time job to feed a teenager, right? Maybe you get a couple of years of respite in there and where you don't have to feed them constantly. But kids look to their parents for food multiple times a day. So when feeding is stressful, we acknowledge as professionals that these stressful experiences are happening for families multiple times a day, which is one of the reasons why feeding issues are so hard and stressful. One of the things that we're going to talk about later that I just want to highlight is that, oftentimes when a child has a feeding issue in early intervention, the light bulb goes off, and that whoever that professional is saying, oh, there's a feeding issue, we want to refer them to a speech language pathologist. And oftentimes that is a very appropriate referral and a good thought. However, it might be a good thought to think, wow, who are those other people that might support the child who has this feeding issue? Perhaps a referral to a mental health specialist could be something that's needed as well, because we acknowledge that when parents have kids who aren't eating well, it can be so hard emotionally and just really take a toll.
So with that said, we'd like to now move into what we know about the impact of feeding problems on relationships, family relationships. And as we were looking through the research and the work that's been published on this topic, we noticed much of the research historically is on feeding dynamics, either in terms of the parent's behavior, the child's behavior and temperament, and the impact in one direction. So of the child on the parent or the parent on the child. And, Walton and her colleagues published a paper just urging us to sort of shift our view a little bit and think about the feeding relationship as transactional, or going in two directions. The child impacts the parent, and the parent impacts the child. And we see snapshots as early intervention providers, but we need to be considering that this relationship is constantly evolving and it's long-term. So there was one paper that I read about parents' descriptions of having a child with feeding problems, describing their experiences. And one parent brought up that it's a journey. And things evolve over time, things change over time. So it's our job to kind of help parents think about that. And it's our job as a team to think about how things have evolved to come to where they are.
So we've got a bunch of pictures here. We really kind of wanted to show you videos, but we couldn't quite figure out the technology to make that work. So you're just going to have to enjoy these cute pictures. But this is kind of just to give you an idea of what normal eating might look like, right? You might have everyone sitting around the table. You might have mom having a little baby on her lap and, giving some of her dinner off of her plate. You might have a dad and a little guy together tasting food. Or you might have just kind of those random experiences where someone is eating and offering food to someone else because it's delicious. And then we know that there's a lot of spoon feeding that happens for all the little babies in our lives. And what you see in all of these pictures is that the parents and the kids are together and they're having a little bit of an interaction and they're having a learning time, and there's enjoyment going on in all of those mealtime experiences. Now, when you look at this picture, I don't know these people personally. You guys don't know these people personally. But what do you see the child communicating to the parent? And then also, what do you see the parent communicating to the child? So go ahead and write it in your chat box of what you think might be going on in this snapshot. Mom looks stressed. Child is looking away. Child is not interested. I see that there's a lot of food on that spoon, and sometimes I think when parents put a lot of food on the spoon, they're thinking, wow, I really want to get this whole bite into your mouth. So we bring this, you guys are saying such great things. The child doesn't look like she wants the food. The mom looks stressed. The child is not engaged. Those are all great answers. Looks like, Janine wrote, looks like an old enough child that should be doing something with their hands. Absolutely. That's a great observation. This is a little kid who should probably be feeding themselves, or at least have a spoon in her hand and be helping with the process. So you all are picking up on the idea that this looks like it could potentially be a stressful situation. So we bring this little exercise up because we want you to think about, how you engage that critical thinking when you're in a home visit. When you watch parents feed kids and you watch kids respond, what are those things that you're seeing?
So I want to just flip back to this slide so you can see all of the different interactions between these parents and children. Look back to this slide as just one more comparison as we move into some of the information about feeding problems and the impact on mealtime dynamics. Many of you named some of these observations, that there's often more conflict attempts to control the feeding, and decrease sharing of pleasure. So I don't see any sharing of affect or pleasure with this mom. And this little girl, there's no smiling. One of you said there's no eye contact. So these are many of the things that we observe, and this is why it's so important when we do our assessments or when we're in the home working with a parent, maybe on other things. We happen to be there for a mealtime. We might take notice of some of these disruptive mealtime dynamics and start to think about how we can help this family improve. We know that feeding problems have significant impact on relationships. We know that feeding problems impact interactions within the family unit. So there's been some research coming out more recently that looks at interactions between not just the mother and the child and the father and the child, but the family as a unit. And what we know is that the disruption and the disruptive behaviors and conflict occurs more frequently during feeding times, but also extends beyond feeding times. So there was a study that Lucarelli and her colleagues released in 2017. And so what she noticed is that conflict extended, as I said, into play interactions, which tells us as we're going into work with our families that we need to remember that feeding problems impact relationships more broadly than just during meal times. We also know that feeding problems impact mothers and fathers differently. So before we go into this, I want to acknowledge that we're talking about mothers and fathers, and there really isn't a whole lot of information out there on feeding dynamics with different family structures. If anyone out there has come across anything, I would love to know about it. We did not come across a whole lot that looked at relationship disruption with extended caregivers, babysitters, daycare providers. So we're going to talk about mothers and fathers here with the idea that we are taking from this that we know feeding problems impact different caregivers differently, and we can then use our clinical reasoning when we're working with our families to think about how we might understand a particular caregiver's point of view. So we know that mothers tend to feel stress from feeding problems and relate it to her own sense of competence. So if my baby's not eating well and refusing the food that I've prepared, it feels like a rejection of me. It feels like I'm not a good mother. So these are some of the things that mothers express in terms of how they felt when they had a child who had challenges learning to eat. Fathers were a little bit different. So stress that dads felt were related more so to the child's temperament. So dads felt more stress when their children had temperaments that could be described as more difficult. And there was an impact of paternal involvement also. So dads who were less involved in their child's care didn't quite feel as much of that stress as fathers who were more involved. So I think, again, bringing this back to our clinical practice, we do a lot of thinking about parents' behavior, and we come into our work with our own personal biases, right? So if we work with one parent primarily and we really don't see the other parent, I think sometimes there's a little bit of judgment that can come in when we wonder, why doesn't this parent want to participate in our work together, in our collaboration? And we urge you to think about the reasons why that parent might be staying away. So we can talk about some of these things. We can help bring parents into the conversation and tailor our interventions for what we know is impacting that particular caregiver. So this is a slide that was created by Dr. Katja Rowell. Some of you may know the book, Helping Your Child with Extreme Picky Eating. But this is from Dr. Rowell's first book called Love Me, Feed Me. And it's just a nice graphic to help us think about this information and synthesize it. So a child has a feeding challenge, a parent begins to worry and maybe seeks some support. And maybe he or she is given inadequate information, poor advice, starts to use some counterproductive feeding practices. So things like sneaking food in with a familiar food, using an iPad or television as a distractor, pushing the child to finish a certain quantity of food. The child then, as is developmentally appropriate, feels that pressure and resists even more. And then it's just a downward spiral from there. And by the time parents get to us, they typically have been in this spiral for quite some time. A lot of the literature actually that we come across, and I know in our own practice, we talk with parents who tell us, I just did not know where to find help. Nobody was listening to me. As Karen referenced before, maybe there wasn't a name for what was going on, but I knew something was wrong. And so one of our goals as practitioners is to help get involved earlier. And we love that early intervention is such a wonderful resource because this program allows us to get involved earlier. So this is another quote that we took from a paper by Black and Abood. What I love about this paper, and this is not on the slide, but if you wanted to dig a little deeper, you can read a little more about this, is that Maureen Black and Francis Abood talk about a framework of responsive parenting. So we're going to start our discussion on what responsive feeding actually means, but we wanted to give you the foundation of what it means to be a responsive parent. So they define responsive parenting as having kind of 4 components. The first one is that the caregiver creates a routine, right? They create a predictable routine and structure, and they have expectations, and they provide sort of this environment that promotes interaction. The child responds and communicates and signals back to the caregiver, and then that caregiver responds promptly and in a way that's contingent. So what that means is the caregiver is responding to what the child has just said or what the child has just done in a way that also is developmentally appropriate. And then as a result of the caregiver's responsiveness, that child then experiences a very predictable response. So responsive behaviors then, to kind of recap, they're prompt, they're emotionally supportive, they're contingent, and developmentally appropriate. And the reason why these ideas are so absolutely important is because this is what helps build secure attachment, trust, and a sense of safety. So we're going to move into how that applies to feeding.
Hold on, don't move the slide. I just want to say one thing. So I really, really love this quote on this slide. I found this a while back and I thought, oh my goodness, this is so much of what I deal with day to day, is that when a child experiences problems in eating or in growth, recommendations tend to be guided by a child's nutritional needs, focusing on the quantity and quality of food and the frequency. I think all of you out there are thinking, oh my goodness, yes, I've been in there where the doctor has been saying we need to get X amount of ounces into this baby. And then you as a provider are thinking, that's the wrong language. I don't know how to get food into the baby,
Absolutely.
right? I know how to support the parents and help them with the feeding relationship and help them build skills and positive experiences. So as a result, health and nutrition counselors may not focus on parent responsivity, and parents may interpret the recommendations as a mandate to use controlling strategies to get their child to eat. We can all agree that this idea of getting your child to eat is not the best thing, right? That phrase is indicative of stress. And we know that these strategies have the potential to undermine the child's trust. Go ahead.
And I'll add something to that as well, as I think as therapists, self-reflection can help prevent us from using some of these strategies. I think that if we're being completely frank, a lot of times when we're working with families, there's a lot of pressure to show progress and to get the child to eat something in our sessions. So I think that this information, while it has a very significant effect on the parental practices, I think that we need to be reflecting and making sure that we're looking at our own practices to make sure that we're sort of maintaining our point of view.
Absolutely, because I think as a provider, it can be easy to sort of know that, okay, this child isn't growing well, we got to get going here, guys, right? We never want that sort of direction of treatment, because we know that we're all trying to help kids and support families and specifically help kids grow. We never want that to undermine this idea of responsive feeding. Okay, so y'all can tune back into your computers. And how many of you have heard the term responsive feeding? Raise your hand. Is this a familiar term to everyone? I really, really love this term, and over the past 6 months or so, I've been trying to figure out where it came from, who was the person that coined it. And to be honest with you, I was not able to find out. I know that the World Health Organization uses this term quite a bit. The American Academy of Pediatrics uses this word quite a bit, and we love this terminology. If you look on the right side of your slide there are some things that kind of help characterize responsive feeding. But, you know, pretty much when we think about responsive feeding, the things that we're thinking about as practitioners is we want to make sure that parents are tuning in to those nonverbal cues that their kids are, you know, offering up to their parents. We know that if a child is refusing the foods the parents are offering, it might make sense to kind of experiment with those things, maybe changing the combination or the taste or the texture. Maybe if it's a younger child, a parent might work with a professional or a physician and use a different bottle or a slower flow nipple or that type of thing. We know that the idea of distraction can kind of influence responsive feeding, right? Because if kids are more tuned into something like, let's say like a screen, they might not be looking to their parents, right? And we want to make sure that kids and parents are connecting because that's so important and such an important part of responsive feeding. And then, the last thing, that's maybe the most important thing, is this idea that, mealtimes are really a place where a lot of emotion happens, where parents can express love to their kids by providing them nourishment. And so we also acknowledge that, when parents are trying to express that love and their nourishment to their kids, and the kids are saying no because they might not be ready for whatever reason, parents can really feel like they're failures and like they're being rejected by their kids. And they're being rejected by their kids over and over and over again. So that's just something to kind of think about. As practitioners, you guys are entering these really tricky situations and trying to help bring parents and kids together over mealtime. So we just wanted to pause here and say who's got questions and how can we answer them?
So we did have a couple questions come through. Actually, the first one is a comment, and from Lynn, who you had mentioned that there weren't a lot of research studies about other primary caregivers feeding. And Lynn just wanted to share that child care providers often talk about mealtimes as being stressful because of the volume of children and the lack of time to individualize.
We see that as well. I've worked with kids in a daycare setting, and one of the things I've noticed is that there are a lot of what we would consider to be maladaptive practices. So lots of pressure put on kids to try food, maybe some not so direct pressure in terms of the order in which foods are served. So I've seen more than once, serving vegetables first before serving maybe the meat or the bread at the meal. And these decisions are oftentimes very intentional. And all this is, I also want to point out there are lots of daycares and preschools that do a fabulous job of implementing responsive feeding practices. But I love that as early intervention providers, we get to go into some of these child care centers and notice some of the feeding practices that are used, because one of the most important things to a child learning to eat is consistency, right? Is that idea of trust and safety and knowing what to expect. And when we're doing all of this work at home around responsive feeding practices and a child spends the majority of time maybe with a caregiver who's feeding differently, that's a real opportunity for us as providers to bring the team together. We're going to talk a lot about teaming a little bit later on, but yes, there is definitely a limited amount of time and multiple mouths to feed. And then parents, this idea that parents want a good report, quote unquote, a good report at the end of the day in terms of their child's mealtime.
Thanks. There's another question that is from Abigail, and she's wanting to know, with those studies of how mothers respond versus how fathers respond, those studies take into account who is the primary feeder most of the time? Do you have information about that?
Yes, absolutely. Yeah. So in almost all of those studies, I'm struggling to think of one that didn't, the primary caregiver was the mother. So a lot of the literature focuses on the mother-child relationship around feeding. And like I said, there's more coming out around father's involvement and roles and the impact of a variety of different factors on how mothers and fathers feel stressed differently. So things like the child's temperament, things like the parent's psychosocial history, the parent's past experiences around, around mealtimes and their own upbringing. But yes, most of the papers that we have included primarily focus on the mother as the primary caregiver.
Okay, I think that probably addresses Abigail's question. If not, she can address the mother. Ask again.
Resources are listed for
and I apologize, I'm going to butcher this name. Luang wanted to wanted to find out if you could just go over some of those counterproductive feeding practices examples. I think this was the slide that went through the kind of the whirlwind of activity.
The worry cycle?
Yeah, I mean, counterproductive feeding practices are, you know, there's lots of different things. That's kind of a catch-all term, but, you know, perhaps you could think about the idea of a child really likes, let's say, like baby food apricots, for example, and the parent says, oh, you really like baby food apricots, I'm going to, like, hide, you know, like a lumpy oatmeal underneath the apricots on the spoon. So it gets into baby's mouth, they're expecting the apricots that they know and love and trust, and all of a sudden it's a sensory surprise. And what happens is that trust is broken. Or perhaps parents are really stressed and their children aren't eating well and they're not growing, you know, and a caring medical professional says, you know, you really need to get more calories into this little one. And so a parent realizes that if they have a screen at the table, it just makes the quantity that their child eats better. And so at that point, the parent has said, you know, I'm really worried about the quantity, so I'm going to use a screen to kind of distract the little one and make that happen. When if you sort of take a more general view and look at that skill, you know, a child isn't paying attention to how full they are. A child isn't paying attention to their parent. A child isn't learning self-feeding skills and isn't paying attention to the sensory aspects of food. So, I mean, there's lots of ideas of things that might be counterproductive. I think, you know, one of the things that we as therapists always think about are, you know, how did families get to the place that they're at, right? We don't want to judge parents and kids, but we want to be really sensitive in thinking about how did you get to this place, where did things go wrong, and how can we help very slowly unpeel those layers so we can, you know, change the direction and start moving to a better place.
And Karen and I were talking a bit before the webinar today about this idea of lack of judgment. I think we've all been in evaluations where we start off by asking the parents, what are your primary concerns? And very often, if we are talking about feeding concerns, we hear a narrative of self-blame and a lack of confidence, and parents are judging themselves. If I hadn't done, I know I shouldn't be. He's not eating as much as my sister's child, and I don't know what I'm doing wrong. So I think it behooves us to just go in with an open mind and, as Karen said, feel compassion for the family, because they know that what's going on, they know it's not going well, right? And that's why we're there to help. Okay.
Yes, I think we can move forward. Just in the back of your mind, there are a couple other questions that I think you're going to be dealing with as we get further on. One about calorie intakes and meal frequencies and duration of meals. So just keep those in mind as you move forward.
Okay. Yeah, okay. We'll absolutely touch on those. So we wanted to have a section on evaluation and assessment. This is not meant to be a technical, you know, checklist of here's how you conduct a feeding evaluation, because that's a really hard thing and that can take years and years to learn and to get good at. So these are just some very general things to think about as we're assessing, you know, kids and parents and feeding skills.
So throughout the next portion of our discussion, we're going to be referring to 2 early intervention documents, and I believe those links are in our references, but we're going to be referring to the 2 sets of 7 key principles, the 7 key principles of early intervention in Illinois, and the 7 key principles for providing early intervention services in the natural environment. And throughout these slides, when we put a key principle on the screen, in parentheses, we reference which list it comes from. But a lot of what we're going to be talking about is reflected in both of these lists. So I wanted to have those available to you. How many of you have seen this document entitled The Clarification of Existing Policy and Procedure Regarding Developmental Services Provided by Speech-Language Pathologists to Children Eligible for Early Intervention? You could just raise your hand. Okay, so we'll go through what's included in this. Not too many of you. So we want to acknowledge this document because feeding is complicated. So this was a clarification, as it says in the title. It clarified what types of feeding challenges should be addressed in early intervention, particularly related to medical stability and whether the feeding challenges were medical in nature or developmental. And what I want to stress is this did not change anything, but I think it arose from some confusion and inconsistencies in terms of how feeding work was being done in early intervention. So I wanted to pull out this particular quote: SLPs in EI may provide services for children with feeding swallowing deficits related to sensory integration, medically stable oropharyngeal disorders, and behavioral issues only. All other feeding swallowing deficits are medically related and should be referred to the child's primary medical physician or medical home for medical intervention. So for the purposes of this talk, we're not going to be diving into what falls on either side, of the line there. But feeding is complicated and it needs to be collaborative. So we want people who are involved in cases where feeding is a concern to really be thinking about their own skills and recognize if there's ever a possibility of medical instability that we need to be referring back to the medical team and collaborating with providers who might be able to provide insight as to what might be causing those instabilities.
So as we begin thinking about the evaluation and assessment process in early intervention, it's really important for us to have a good idea of what happened before the child and the family met with us on that day. One thing that we always think about is that, kids who end up in early intervention might have gone through a lot in the early part of their lives, and their parents might have gone through a lot. And so when we as providers go in and we have those early, reports or documents or information from the service coordinators, it helps us ask really sensitive questions. We know that when parents have to tell us things that have happened to them in the past, it has the potential to be really stressful for them and maybe bring them back to those experiences of trauma or, things that might have been traumatic for them. We understand that, trauma is individual and specific for families. So, having an extended NICU stay is something that could be really, really hard for, a mom or a dad to talk about and kind of relive as they're sharing that. It's also really important for us, just as, good clinicians, to know what are those medical things that a child went through early in life. If a child had an NG tube for a long time, we might be thinking, I wonder if that child's face is sensitive. Or, that might be one of the reasons why spoon feeding is hard. So really, the clinical reasoning process starts with us getting to know families well. We also know that when we get to know families well and we ask good questions and we listen without judgment, that parents come to trust us as professionals. Our second thing we always want to make sure we're looking for when we do an evaluation or an assessment is we want to see, how does the parent feed the child? I think it can be really easy for us as professionals to say, let me do it, or okay, let me try it, because we all have our own way of doing things, and we're all caring and we're trying so hard to help. But when we watch parents feed kids and we watch how kids respond, that gives us so much insight into what might be going right, but then also what might be hard for the parent and the child together as a dyad.
I just also want to point out that I think we've all been in an evaluation and realized we need to see this child eat, and oftentimes if we haven't connected with a parent prior to the evaluation, I know these evaluations are scheduled in all kinds of different ways. Some service coordinators prefer to do the scheduling, some providers do the scheduling when they receive a referral, but I like to always make sure that I'm reaching out to a family, giving them a sense of what's going to happen during the evaluation and asking them to have some foods prepared that we might be able to observe their child being offered. So that's really important because the level of stress and anxiety in these evaluations is so high. And if we all of a sudden say, oh, can we see your child eat? As a parent, I would think to myself, oh my gosh, what am I going to get? I don't know if I have anything in the house.
Are they hungry?
So a conversation in advance is so important to set the parent's expectations that that's going to be part of the evaluation.
Great. And then, we're also considering all those psychosocial factors and those things that, you walk into a home visit and you get a general sense of, oh, this is a really happy home, or, oh, I feel like there could be stress here. So, we just want to really make sure that we're thinking about all the aspects that can affect feeding as we move forward.
And Karen and I are excited to be presenting a longer format talk in June. We're going to be presenting this workshop in an expanded version in a couple of different locations in June, dates to come. But we're going to dive much deeper into how do we really assess all these different psychosocial factors and relationships. There are a number of instruments out there and tools that can be used, and we're starting to use some of those in our own practice and have found them to be really helpful.
So this is just to highlight the fact that, early intervention and the key principles with early intervention really goes along with these ideas of making sure that, the intervention that we're providing as a result of this assessment is dynamic and individualized to each specific family. And we also want to make sure that the outcomes that are reflecting the direction where we're headed, with our intervention, with our therapy, it needs to be functional and it needs to be important to family. One of the things that, I always think about in my own practice is, if mom and dad don't think that this is important, they're not going to pay attention, right? They're going to cancel those appointments. They're not going to understand why I keep showing up at their front door. So it can be so important to have a very frank conversation, perhaps after you do your assessment, perhaps after you have a couple visits, or at some point during that where you say, okay, what's been important to you in this process? What are those things that we've done together that you think are working? Or, sometimes I'll ask parents, what do you want to work on this week? I think as providers, it can be so easy to have this idea of, okay, you pull out your pad of paper, you scribble down that home program, and you give it to mom and say, okay, work on these 2 things, or work on these 3 things. But I kind of like to say to parents, what might you want to work on this week? I love doing that because it helps me know what that outcome is that might be important to mom or dad. And then also, it helps me realize that sometimes what mom says is important to her, or the thing that I've emphasized, is not the thing that I want to emphasize. And I realize that I have made a mistake. So anyway, we just really, really want therapy to be functional and to be meaningful for families, and we want them to see that from day one.
So I just took a quick peek into the chat box, and we're going to kind of zoom through this question section, but I did see a question regarding the role distinction between occupational therapists and speech-language pathologists regarding feeding. We're going to get into teaming in a little while, but what we want to communicate is that Karen and I both feel that it's not necessarily the discipline that lets the title that lets you know if a person is an appropriate provider. As Karen said initially, she's had lots of advanced training in feeding challenges, and there are many speech pathologists who have had little to no training in graduate school or in their postgraduate work. So what we try to convey is how important it is to know your fellow providers and understand their areas of clinical interest and their experiences. And though we do look at feeding from different perspectives, we agree on a lot of things, although Karen has vastly more experience in terms of sensory processing than I do. We share a lot of the same knowledge. So I think that in our region of the country, historically it's been speech pathologists that work on feeding challenges, whereas if you go out west to California, you're going to encounter most of the OTs are doing the feeding practice.
And the OTs are the people in the hospitals doing the swallow studies, just like the speech language pathologists are doing here. So I think it's really important to know those people in your community that just love feeding kids and supporting families. And if you're a service coordinator, know who those folks are. It's really great when documentation is written in such a way where you could refer to a speech language pathologist or an occupational therapist, depending on who that person is that might have room on their caseload and can help that family. And I think another thing is, like we said many times so far, that kids who have feeding issues often have lots of things going on, right? It's complicated. And so sometimes referring to a speech language pathologist and an occupational therapist and mental health support together is really the perfect combination, because we all can help each other when we're working with families that have a lot going on. Okay, so we're going to keep zooming because we're on a little bit of a limited time frame here, but we just wanted to talk about treatment. And we wanted to reference those key principles that you all know that the whole point of early intervention is to encourage active participation of families in daily routines. So we want to make sure that those early intervention strategies that we're using with families just kind of happen during the day. We don't want to give families long lists of extra things to do because life is crazy enough.
And the part of this principle that I absolutely love is that it's the parents who provide the real intervention. And I think we all know this, but I really like to keep this in the front of my mind as we talk about treatment strategies.
Okay, so how do you build trust with families? This is a question that I have thought about so many times, because if families don't look to you as a provider, as someone that they can really share the real parts of life with, that you don't oftentimes have as much success in therapy. So what we want you to do is to go back in your mind and think about that child that you thought about at the beginning, that family that perhaps caused you to sign up for this webinar, and think about how did you build trust with that specific family. And go ahead and write that in the box, in the chat box. Okay, so people are saying things like, you're listening to parents, communicating, being really honest, doing active listening, which is so wonderful.
Not being judgmental, I love it. Being open-minded, great.
Supporting parents and telling them, the things you're doing are on the right path. Being really individual in the different goals that you make, absolutely. And really, I think for myself, sometimes I build trust with parents when I show up on time, even though I'm always running 5 minutes late. Right? Parents trust that I will come to the visit that I schedule.
You will come there.
So even those simple things can build trust. So we're going to talk about this more and more, throughout the rest of our time here together. But these are just a few ideas that we have in terms of building trust. We want to educate parents about typical infant and toddler feeding, because we know that when we as professionals understand what's going on and just what's a part of typical development, we can share that with parents. Sometimes kids get to be about 18 months old, and all of a sudden their child who was eating really well, begins to struggle. And we go, oh, they're a toddler. Almost all toddlers eat, almost all toddlers struggle to eat new foods. So those are just helpful things to share. We want to have really appropriate expectations for ourselves and for their families we're working with and for the kids that we're working with. So, sometimes it takes a really long time for kids to make progress that parents can see. And so we want to celebrate those little benchmarks of progress, and we want to help parents to know that if it takes them a while, it's okay, because kids need lots of time and lots of practice to get better at skills and to gain new skills.
And don't you think a lot of that has to do as well with helping a parent understand the impact of his or her child's history on his or her participation in therapy? Absolutely.
We know that kids, are reacting as a result of the experiences that they've had. So if it takes them longer, that is okay. They are setting the little one, the child is setting the pace, and we as the providers are setting the direction. Another thing that I feel so strongly about is we always want to start with what's working. And this is so important in those kids who are maybe we think about as like sensory feeders or the picky eaters of the world, is that if you take a little one who is struggling with a certain texture of food and you say, okay, we know this is hard, go for it. They're going to say, no thanks, I'm out of here, right? So we want to start with those things that kids are really good at, that feel comfortable and feel fun, and then slowly change things so that kids are trusting us as we, are helping parents to make those changes. It's also so important to highlight to parents what's working, to say, wow, you did such a great job offering that. Or did you see your little one do that? I don't think they've ever done that before. Because we really want parents to feel confident as they're offering food to their kids and as they're learning how to be the master feeders.
And as we're talking about building trust, a lot of the things that we're talking about implementing are things that not only build trust between us and parents and caregivers, but all of these things are supporting the parent's ability to build the trust between him or her and his or her child. So the trust is going in all directions, and the more trusting our relationships are, the more buy-in we'll get from the family and the faster the progress.
Absolutely. We also know that, feeding issues aren't always those things that resolve overnight. And so you might be working with families for a period of time, and that's okay. So we just encourage you to think about having ongoing conversations of a child's strengths and of a child's needs. This is one of those things that help parents, I think, be less anxious about, how long am I going to be in therapy, or what am I going to work on this week when the therapist shows up at my house? Because we want to make sure, again, that we know what's important to parents and that we are targeting those things and having those important conversations when we're actually in the home with the family.
So as we're talking to parents and educating them about all of these different things, we need to always remember what we've been saying all along, and that's that feeding happens in the context of relationships. So my primary goal, and I think it has a big impact as I'm starting to work with a family, is to figure out how much stress is this parent feeling. And it can take a little while to establish a relationship and a rapport before that parent feels comfortable communicating to me things about their emotional experience feeding their child. So the slide that I highlighted earlier, if you think back to when we talked about how mothers internalize the stress from mealtimes, it's so important that we're pulling in our colleagues who can support parents' mental health, because we know that this is the primary consequence of stressful mealtimes for moms, is that they really are feeling a lack of confidence. And I think that as we collaborate around these issues, it really opens up the conversation a lot more.
Can I say one thing?
Please.
So, one of the things that we struggled with in our practice is that sometimes by the time we make a referral to a mental health practitioner, it's kind of, well, that would say that it's too late, but maybe we've missed that window. Also, I think when we refer later on, there's maybe stigma, and it's a little bit of a harder recommendation for parents to think of, oh, you want me to see a therapist? You don't think I'm being a good parent? Like, I thought only parents who didn't have it together work with mental health support. And so, we just maybe want to be a little proactive in saying, oh, wow, this is a high-risk family, or this is a family that's got a lot going on. Maybe we could support them earlier. And then the second thing is, we can be a little bit creative about helping parents find maybe peer support. Maybe they could be in a parent support group. Stephanie and I are involved with a nonprofit called the Chicago Feeding Group. And one of the initiatives of our group is to connect parents who have kids who have feeding challenges. Because we know that, a mom who has a baby with a feeding tube, when she can hear from another mom that has a baby with a feeding tube, that is a relationship that is so supportive, and more supportive than anything that I can offer as a professional.
Absolutely. And we want to also point out that though the group is called the Chicago Feeding Group, we would love for all providers of all disciplines and parents and students to participate in the conversation. So just sort of building on the point that Karen just mentioned about pulling in our mental health colleagues earlier, even at the point of intake, we saw that we have a bunch of service coordinators joining us today, and we're so excited to see you all here. And some of you I've even had the pleasure of working with in the past. We think that in most situations, it is appropriate to pull in a mental health professional from the beginning. And though it may complicate scheduling and may complicate and extend the conversation in the initial evaluation, what we know about best practice in addressing feeding problems is that we must address that psychosocial component in order to make good progress. And I love this idea of thinking about reframing it and removing the stigma when we're talking to parents about why we've asked our colleagues to join us. So thinking about the caregiver's learning style, Karen touched upon writing down a bunch of things on a piece of paper and handing it to the parent and walking out the door. Obviously, that's not the optimal way to talk about our strategies that we'd like families to implement. But thinking about whether or not the parent learns best through demonstration. In early intervention, our role is to coach parents and help them to feel confident implementing the strategies and the things that we're recommending. But we really want to make sure that we understand the parent's learning style and that we understand, any language barriers that might be present. We really need to make sure when we're working with our families for whom English is not their primary language, that we have an interpreter there helping us. A lot of the implications and sort of the subtleties of our language and the things we're trying to communicate as we talk about a lot of these components of our treatment plan get lost in translation. So with those families, we really want to make sure that we're checking and rechecking and making sure that parents and families really understand what we're discussing with them. We want to, over time, as we establish a trustful or trusting relationship, explore the parents' experiences with food. I don't know about you, Karen, but I would say in nearly all of my work with families with kids with feeding challenges, as the relationship continues, the parent always begins to talk about their own experiences with food. I'm thinking back to a particular case of a little guy I worked with who had a diagnosis of pies. His mom,
which is a very kind of terrible food allergy to have.
It causes lots of vomiting and lots of stress. And this mom eventually revealed to me, as we talked about the fact that this process takes time, and her son was a very, very cautious, anxious little guy when he came to the table. She told me about an experience she had when she was younger as a pickier eater herself, when her mom told her she was not to leave the table until she finished her mashed potatoes, which she absolutely hated, but had no choice and ended up throwing up. And I tell this story because that experience informed her parenting. And I think that a lot of times when we're talking about feeding practices, it's important to think about what a parent has been taught through his or her own experiences. Is there something you want to add to that?
Absolutely. And you know, just the very last thing that we want to touch on as we're thinking about building trust with families is the idea that people come from different parts of the world. You know, people come into the early intervention with different ideas about food. They might have different socio and economic backgrounds from us as providers. And so we want to be sensitive to those things as well. One thing I've learned in my practice is that in certain parts of the world, it is a parent's job to get their child to eat, no matter what the cost. And so, you know, as a white woman who grew up on the north side of Chicago, you know, in my mind, I think, oh my goodness, this mom is force feeding the baby. But, you know, for that mom in the situation, she's doing everything that she's been taught to do as a good parent. And so, again, we want to reflect upon the own opinions that we bring in to our practice as providers and think about, why might a parent be feeding their child in this way? How can we build trust with a parent so we can explore those things that might be making it hard for a child to eat? And then, you know, really sensitively think about making suggestions that might help the child or the parents to overcome those things that are making feeding difficult. So that can be a really tricky thing, and it can be great for us as providers, you know, to support each other, to ask lots of good questions, and also to ask honest questions to families when we don't understand what might be going on.
I think it's also important to make the point that these parents and caregivers are often impacted by extended family members, you know. So how many of you have worked with a family and maybe you work primarily with the mother or the father, and you hear often about how the grandmother doesn't really understand what we're trying to do and doesn't think that we're approaching things the right way. And, you know, her feeding practices may be deeply rooted in her upbringing and her culture. So it's really important to bring extended family members into the conversation for that reason.
We love it when lots of people feed kids because we know that feeder diversity is oftentimes one of those things that can be really hard for kids when they have feeding challenges. So when we can think about, you know, being a support to maybe the mom or the dad and saying, hey, why don't you invite your mother-in-law? You know, let's let her be part of the discussion as well. It's kind of fun for us that we can be a neutral third party and that we can support the whole family in feeding a child. We also know that, you know, when we support whole families, it kind of helps things be a little bit more normal. And we know that oftentimes kids end up in early intervention because they've gone through some really hard things, maybe some really hard medical things, and then they are, you know, on their journey to kind of normal child development. And so it's really a privilege for us to help parents move in that direction. You know, as we're thinking about intervention in general, we want to think about how we're helping parents in this process of therapy. So, you know, I always like to start my sessions by, you know, asking the mom, hey, you know, why don't you show me what you've been doing this week? Or sometimes moms will say, oh, Karen, you know, what should I feed my baby? And I'll often respond and say, oh, well, what would you feed him if I weren't here, right? I don't want to ask moms or dads or grandmas, you know, to do things that are above and beyond kind of their normal schedule. I want to see what normal feeding looks like. We know that, you know, intervention happens every week, but assessment happens every week too, because little kids change from week to week. So when we get an idea of what that feeding relationship looks like, you know, we can try new things. And then, you know, maybe after mom or dad or grandma feeds the little one, I might say, oh, can I have a turn? And then we'll take turns. We want to make sure that parents understand those recommendations we're making. We want to make sure that parents understand what their child might be telling them through their nonverbals. And then we want to make sure that parents have a game plan for every mealtime, right? If this is the thing that's really hard, how do you respond, right? Because when parents kind of know what they can do and what their options are during the week, they feel better and they're less anxious about dealing with something that might be hard or unexpected for them. Okay, so, you know, we know that communication is so important, and it's funny, as Stephanie and I were talking, we thought about 5 or 6 other things we should have, you know, added to this slide. So here's 2 quick points as we're, you know, coming to the end of our discussion today. We really want to think about early intervention as a place where we can begin to demedicalize feeding struggles, right? So perhaps instead of using words like bolus or lateralize, we might use words like, oh, that bite of food, or oh, your child can move their tongue to the side of their mouth, right? We don't necessarily need to use medical terminology to communicate well. We can just use everyday language, and parents can, you know, feel good about using their everyday words with us. It kind of levels the playing field and the relationship between the parent and the, you know, the quote professional therapist together. We also just wanted to give you these little, you know, bullet points on the side there of things that maybe you would try in your practice. So, you know, we've all been in that home visit where things are going really, really bad. And you're sitting there as a therapist going, oh, this is not what I want to happen, right? So, you know, if you're trying to point that out in a sensitive way, you might say, oh, I'm noticing that your little one is having a hard time with that. Let's talk about that, right? It gives you some neutral language to explore something that might feel hard for you as a therapist. Sometimes it makes sense to say, what would happen if we try this? Because it gives you as a therapist a little insight into, you know, what mom or dad might be thinking. And it might give you a door to open and say, could we make some changes here in a place that maybe you couldn't make those changes before?
And, you know, I think it's so important to set the stage with the parents, setting expectations. We talked about that a bit, but it's so important because I think a lot of times parents feel like we are changing how they parent. And in many ways we are, but we want to do it in a way where they're not feeling judged, but instead we're collaborating. And so I think these statements really send that message. But from the beginning of the therapeutic relationship, I find it to be really helpful, and I think you do too, Karen, to talk about what therapy is going to look like. Many of our parents have had experiences with other therapists, maybe outside of early intervention, where the parent sits back and the therapist is sort of doing the feeding or doing the handling. And in our sessions, things really look different. Early intervention is a coaching model, right? And so I think that when we talk to parents about how that looks in a feeding therapy session, it helps them to understand what's coming.
Yeah. You know, we also want to make sure that we're giving parents permission. So before we go out and do something or suggest something, we might say, hey, would it be okay if we try this week? Or would it be okay if we try this next week? And then, you know, parents know that if we frame things in that way, they might say no. Let's flip to the next one. Okay. Yeah. So we're going to keep going right here because I think we're actually kind of coming to the end of our time together. Okay, so if we think about that family we asked you to reflect on at the beginning of our talk today, what are some of the ways that perhaps you've used some of these strategies and some of the things that we've talked about today in your practice? Because we know that you guys are skilled providers who really care about family and are, you know, already doing a lot of these things as you're really building trust. Go ahead, type it in the box.
So I think we can maybe then, if nobody has
specific things, we're going to keep
going. So we wanted to just highlight a couple or a few responsive feeding strategies, so things that you can put into practice later today or tomorrow. So modeling positive eating behavior at mealtime. And we want to just make sure that we communicate to you all that these strategies are rooted in evidence. This is evidence-based practice. And a lot of the evidence comes from what we know about early developmental learning and socialization literature, but there has been very focused research on feeding strategies and their outcomes, specifically the fact that when we model positive eating behavior at mealtimes, whether it's trying a new food or eating without distraction, children are more likely to imitate us. So we encourage shared mealtimes for that reason and a myriad of other reasons. We avoid using pressure at mealtimes because what we know is that children who are pressured to eat, whether it's an increased volume of food or pressure to eat certain foods rather than other foods, that it tends to have the opposite effect. And so for that reason, we don't advise using food as rewards because we find that it ends up devaluing the food that a child has to eat in order to get that food that's the prize. Mm-hmm. And as we talked about earlier in the talk, we respond promptly to a child's cues of hunger and satiety. When our kids send us those signals that they are done and they are full or they don't want something, we're going to respond promptly.
Yeah, so we know that early intervention is collaborative at its heart, right? And we just want to touch on that collaboration in terms of feeding. As we said earlier, there's oftentimes lots of folks involved in early intervention, including, all of these people: occupational therapists, speech-language pathologists, pediatricians, physicians, allergists, medical professionals, and medical specialists. So lots and lots of folks. But just two quick things to highlight. The first one being that the family really needs to be at the heart of the team, right? It needs to be the parents' priorities. Mom and dad are the most central people on that team, and I think that's something that we sometimes forget about people who have letters after our names. The other thing, I just would like to encourage you to think about is the idea that sometimes we forget we're on teams because as early intervention providers, the reality of our lives is that we spend a lot of time in our cars driving around. And so when we think about the idea of being on a virtual team, when we think about taking the time to call the pediatrician or to coordinate with the speech-language pathologist, that's really in line with the early intervention model, and it's providing best practice because when we're all on the same page, parents begin to hear the same thing from all of the people who are making home visits, and that can be really wonderful for parents when they're getting a consistent message from all of the people who are working with their family.
So team collaboration and communication. So as Karen said, we really want all members of the team to be aware of the plan so that the parent is supported throughout the week. When multiple providers are coming in and parents are asking questions about eating or you observe something going on, we just want to make sure that our messages are in line with what everyone on the team is doing to work towards the outcomes that we set in the IFSP. And we want to make sure that we're using our IFSP development time wisely, right? We have this time for a reason. I want to point out that if the physicians are written into the IFSP, then we are allowed to use IFSP development time to talk with a physician. And this is important. I think there's some confusion around this. I know there was a time where I was very confused about this, but I love that early intervention provides us with the opportunity to use these minutes to collaborate and to connect with team members outside of early intervention, like child care workers, teachers.
So this is really our last slide for today, but we want to make sure that all the things and all the interventions we're providing to the families are based on, research, best practice, and are following all the laws and regulations in our state. And, you guys are doing a great job of following those laws and those resources and trying to, adhere by best practice in your own practices. And so we really appreciate you spending the time to listen today and to be part of the conversation. And I think we're going to use the last few minutes here to take a few questions.
Yes, I wanted to let didn't want to let a couple of questions go by. Ami had asked, do you use a specific set of norms when evaluating a child for feeding skills so that you can show true delays by numbers for qualification purposes?
So right now, there is not an EI-approved assessment tool to measure feeding. So there are a number of assessment tools out there, and I do, in my evaluations, attempt to put sort of an age level on feeding, but I think what makes it a little bit challenging is we need to remember that we're really looking at a child's developmental stage rather than an age, although we need to give an age level in terms of that child's adaptive development. So one of the things I really like to use as a guide is the Pre-Feeding Skills Assessment, a global approach from the book Pre-Feeding Skills by Suzanne Evans-Morris and Marcia Dunn-Klein. It's a nice comprehensive guide that gives us a sense based on what the child is doing of approximately what developmental age they're functioning at.
And if you have that book at home on your shelf, that book is about the size of a phone book. It's a textbook and it's huge, but in the back there's different appendices and different charts that help you figure out where a child might be in terms of their different age and then skills and how those two things could perhaps be paired together.
And you can reproduce it. We're allowed to make copies. So
and if you don't have that book, you probably have a colleague who has that book because it's around.
Okay, thank you guys. We are out of time. If you would put down in the chat box in the main room when you're extending the session about folks who are interested in question. We had questions about the use of feature. We had questions about the use of typical ages for children to start spoon feeding themselves, and which I think are all valid questions, but we're just out of time. So with that being said, if you could post that in the chat box, that would be awesome. And for everyone else, I know you probably all need to go. I just want to remind you that there is to look for that email as well to get your certificate of attendance. I want to thank Stephanie and Karen so much for this great webinar. I mean, we could just keep going on and on. Right. But thank you all so much for your participation and sharing your information and questions. And please be on the lookout for our next winter webinar series, which is in a couple of weeks. With that being said, everyone, thank you so much, and we'll see you next time.
Thanks so much.
Thank you.